mental health professionals break down those questions into various steps. Okay? These are the steps. Question 1, why has the person done what they've done? Is dealt with in these first 4 steps, through gathering relevant information, rating the presence of risk factors, rating the relevance of risk factors, and developing a formulation. A formulation is the integration of risk factors into a meaningful individual theory of violence for a given person. It helps answer that question, why has the person done what they've done? Is it because of difficulties in coping and stress, which leads to substance use problems, conflict at work, conflict with relationships? Is it because of paranoid delusions? Is it because somebody is psychopathic and so they lack empathy? It's the explanation of why someone has done what they've done. The second question, what are you worried they might do in the future? If they're discharged, what are you worried they might do? This is dealt with steps 5 and 7. What's the risk level? Is it low, moderate, or high? And what are the scenarios of violence? A scenario of violence is a possible way that violence might manifest. So of course the person could always do what they've done in the past. Somebody's committed a homicide while they're psychotic. Somebody's committed a sexual offense. We always have to consider what we call a repeat scenario. But they may do something somewhat different. They may offend against a different person for different reasons. Their violence could get worse. So we need to also consider what we call twist scenarios, worst case scenarios. The last question, what are we going to do about it? That's addressed through the development of case management plans. So understanding the formulation, the risk factors, this leads into what we call the scenario planning. And that is meant to inform case management. How do we monitor people? What warning signs should we be looking for? What's the best treatment to line up with the risk factors they have? What level of supervision should there be? And is there anything that we can do to help potential victims through victim safety planning? I'm not going to talk about these in detail, but these are the risk factors on the HCR-20. So on the historical scale, at any point in a person's life, have they had a history of violence? Have they had other antisocial behavior? Have they had relationship problems, employment problems, substance use problems? Do they have a major mental disorder? So in your setting, probably this one would always be answered yes, right? But this instrument can actually be used in settings where people might not have a mental disorder. Prisons, for example. Do they have a personality disorder, like psychopathy? Have they been subjected to traumatic experiences? Do they have violent attitudes that support and condone the use of violence? And have they shown poor treatment or supervision response or compliance? So we look at those across the person's lifespan. Then we focus our attention to how have they been doing for the last 6 or 12 months? What kind of treatment progress are they making? Do they have problems with insight? So self-awareness into their mental disorder or proneness to violence. Do they have violent ideation? Have they been thinking recently about hurting people? Or threatening to hurt people? Active symptoms of major mental disorder, do they have emotional or behavioral instability? And do they have a current treatment or supervision response problem? So we focus historically, then we take a look at how they're doing recently, and then we shift our attention to how do we think they're going to do in the future? So if they're discharged, what will life look like for them in the next 6 to 12 months in terms of, do they have any problems with professional services and plans? Do they have good plans in place that address the risk factors that they have? Is their living situation stable or unstable? Are they going to be living with people they don't get along with? What kind of activities are they going to fill their day with? Productive ones? Unproductive ones? Do they have personal support from friends and family? What's their treatment or supervision response going to be like in the future? And then how are they going to deal with stress? What are their coping abilities? So we have operational definitions for each of these risk factors, the worksheets, you can record your responses to them, the evidence for them. Then we encourage people to think, well, of the risk factors that they have, which ones are most relevant for understanding their violence? You could have 2 people, both of whom have substance use problems. For one person, it could have nothing to do with why they're violent. For the other person, it could be everything. Every time that they use substances, they're violent against a partner, or they're violent against their family. For other people, they might use substances and just pass out on the couch. So I want to talk, excuse me, talk a little bit about some of the research, given the research themes within this evening's presentations and the purpose of the presentations. And there'll be some researchers in the room, I realize. There's also clinicians and people who do both, and administrators. I always feel a duty to tell people a little bit about the research, because these are high-stakes decisions, right? And using an instrument like the HCR-20 or for any type of risk assessment measure, it's important for you to know what is the degree of evaluation of it. First published in 1995, version 1 in 1995. The first 4 studies, they weren't yet published, but we did a handful of studies in 1996. We made a few revisions based on that, and version 2 was published in 1997. First published article was 1998, but then there have been hundreds more since then. People around the world, I think we're all facing the same struggles. How do we evaluate risk for violence? In Canada, in 1995, that came just a few years after a change in the law. So we've heard about changes in the law here in Egypt to try to formalize the release procedures, right? It was the same situation happening in Canada in the early 1990s. It used to be that a forensic patient could be held, and the way the law read, of course we have British influence in our laws, it said, until the pleasure of the Lieutenant Governor is known. Until the pleasure of the Lieutenant Governor is known. Meaning there are no criteria for discharge. It's whenever the lawyers and the government say, well, this person can get out now. 1992, that was changed. And there's now a big piece of legislation that says